Rickets, one of the important topics in pediatrics. By rickets, we mean we have failure of osteoid to calcify in growing bone. In other words, it is defective mineralization of bone. Bone is formed of matrix and minerals. Failure to mineralize the osteoid tissue, this is rickets. Okay. Rickets is disease of young children, usually less than 3 years old, who have growing bone. When we have defective mineralization in older ages, we call it osteomalacia. The highest risk for rickets occur in breastfed infants, okay, with pigmented skin, as breast milk contains little or no vitamin D. This is very important, and so vitamin D supplementation is recommended even from 0 day of life. Sunlight or UV light of the sun is the main source of vitamin D synthesis through its effect on the skin, 7-dehydrocholesterol, producing the cholecalciferol or vitamin D3, which is the main source of vitamin D, or vitamin D can come from fish oils, okay, and this is called vitamin D2 or ergocalciferol, which is converted into D3 in the body. So either from the UV light, which is the main source, or from ingestion of vitamin D2. Vitamin D2 and vitamin D3 both are inactive forms and need activation first in the liver to form the 25-hydroxy vitamin D, and then in the kidney to 1,25-dihydroxy vitamin D by the effect of 1-alpha-hydroxylase enzyme in the kidney. Deprivation or inadequate exposure to sunlight is important risk factor for rickets. The most common cause for rickets is nutritional deficiency of vitamin D, either inadequate oral intake or inadequate exposure to UV light. But note that rickets, it is not vitamin D deficiency, but it is defective mineralization, either due to vitamin D deficiency, which is the most common cause, or can be due to other causes as a differential diagnosis. Even in sunny areas, inadequate exposure occurs if the infants are deliberately covered. Okay, we usually recommend the babies or infants to be exposed on exposure to the sunlight. Vitamin D is an active form of vitamin D, which is 1,25-hydroxy vitamin D, has actions on the intestine, increasing the absorption of minerals of bone, which are calcium and phosphorus, and has actions on the kidney in the form of increasing the reabsorption of these minerals from renal tubules, limiting its excretion in urine, and has actions on the bone through stimulation of calcium and phosphorus deposition in bone. So all actions of vitamin D end by increasing calcium and phosphorus levels in extracellular fluid, calcification of osteoid. Primarily this occur at metaphysis of long bones. So effects of vitamin D deficiency or rickets usually appear at the region of metaphysis. Starting with vitamin D deficiency, which is the most common cause. When vitamin D is deficient, initially we have hypocalcemia due to reduction of calcium absorption from the gut and reabsorption from the kidney and so on. This hypocalcemia stimulates parathyroid hormone release. Parathyroid gland has its main priority to maintain normal levels of ionized calcium, because hypocalcemia is dangerous and can be associated with arrhythmia and even cardiac death. So after parathormone level increase, it functions on the same side, the intestine, kidney, and bone, aiming at increasing serum level of calcium. So at level of the kidney, it increases the calcium reabsorption from renal tubules, but increase renal phosphate loss. Okay, to maintain calcium phosphorus product. As you know, we have calcium phosphorus product is constant at the level of renal tubules. So parathormone increase phosphate loss and increase calcium reabsorption. Also, parathormone act on the bone by increasing bone resorption It remove calcium from bones to serum to increase serum level of calcium. So serum calcium is low initially, but then become normalized by the actions of paras hormone. Alkaline phosphatase is released from the active osteoblasts during the disease process, which leaks into the extracellular fluid, and so we have high serum levels of alkaline phosphatase, one of the earliest clues of rickety disease. Okay. This is the consequences of vitamin D deficiency. When we try to mention the signs of rickets that should be searched for in every child coming to your clinic, as it is quite common entity with easy treatment. Okay, so usually it is a useful way to count the manifestations of rickets from upside down, starting from the head, noticing the macrocephaly, the frontal bossing, the wide anterior fontanelle or delayed closure of anterior fontanelle, down to the delayed teething or delayed dentition, down to the chest, observing the rachitic rosaries, okay, and the ribs, also the pectus carinatum deformity, the Harrison sulci. These are three important signs in the chest. Even severe rickets can result in restrictive pulmonary function, okay, due to thoracic cage deformity. Down to the abdomen, abdominal distension can be noticed due to the generalized hypotonia associated with rickets. Also, to the organs in the form of palpable liver and spleen can be found. Down to the limbs, upper and lower limbs, broadening at the site of metaphysis is a very important clinical sign. Here at the wrist and at the ankle, also at the level of the ankle, the Morphin sign is characteristic, where we have a groove in the medial malleolus can be felt. Due to weight bearing on weak bones, deformities of lower limbs are common in the form of either bowing of legs or knock knees. So this is a useful way to enumerate the clinical manifestations of rickets that can occur, as we have mentioned, due to vitamin D deficiency or due to other causes like vitamin D resistant, for example, or other causes. So we have widening of metaphyseal region due to accumulation of the osteoid tissue that is not calcified. Okay. Also we have softening of the bones, and this causes deformity by weight bearing. We have bow legs or knock knees. We have weak ribs, okay, which lead to Harrison sulci and pectus carinatum. These are useful pictures for the rosaries. Here, by this way, elevating the arms of the patient, we can visualize the rosaries here, which are dilated or broadened osteoid tissue at the costochondral junction. Okay, this is the site of growing or growth in the ribs. So these are rosaries that can be visualized or palpated. Okay, this is the pectus carinatum. Okay, due to weak bones, and this is the Harrison sulcus. Harrison sulcus is caused by the diaphragmatic movement. This is the site of insertion of diaphragm, and when diaphragm pulls on weak ribs, okay, it results in this characteristic Harrison sulcus. So we need high index of suspicion, okay, as it is usually asymptomatic. The mother may not complain at all from any symptoms related to rickets, but usually can present with the delayed gross motor milestone acquisition, delayed walking usually, for example. Rarely hypocalcemia can be severe, resulting in tetany that can complicate an acute intercurrent infection. So he is rachitic, and when he developed gastroenteritis, for example, this precipitates severe hypocalcemia presenting with convulsions. Frontal bossing, craniotabes also is characteristic. You can press over skull bones, and because they are weak, they can give you an indentation like a ping pong ball. fall. This is one of the earliest manifestations of rickets also. Delayed closure of anterior fontanelle, wide sutures, delayed dentations, rosaries, Harrison grooves, pectus carinatum, kyphoscoliosis, also one of manifestations of rickets, especially in severe cases that are related not to vitamin D deficiency but related to other genetic causes maybe. So broad ends of long bones at wrist and ankle, Marfan sign, bow legs or knock knees due to weight bearing on weak bones. Also short stature is very characteristic, especially when rickets is not treated, okay, or if it is resistant. So short stature, and short stature here is disproportionate, which means that the ratio between the upper segment of the body to lower segment of the body is not normal in relation to age, and this is usually due to the deformity of lower limbs. Being bowed like this will result in shortening of lower segment of the body, giving high ratio between the upper to the lower segment of the body. Generalized hypotonia is present in rickets, and this is the cause of delayed motor development in these cases. Also notice the broadening here at the wrist joint due to enlarged metaphyseal region. Diagnosis of rickets is very easy. With the earliest signs of rickets are the radiological features plus the high alkaline phosphatase levels. These are the earliest signs. Doing a plain X-ray at level of ends of long bones will show you the characteristic osteopenia that can appear here, but it's usually not sensitive sign, but the characteristic broadening, fraying, and the cupping of ends of long bones is characteristic of active rickets. Bone profile, very important. Ionized calcium usually done and can be found to be low or low normal. Serum phosphate is characteristically low. This is a consistent feature. Also high alkaline phosphatase is a consistent feature in rickets. Usually the diagnosis is based on these two, the radiograph plus these tests of calcium, phosphorus, and alkaline phosphatase. If we have done calcitriol levels, the active form of vitamin D, we would find it low due to vitamin D deficiency. Also parathormone would be found to be high, but usually we in straightforward cases we don't go on to these tests. So how to manage the management simply in vitamin D replacement. Prophylactic dose, a very famous dose of 400 international unit of vitamin D given daily orally using oral drops or syrups. This can be started from the 0 day of life and continued as long as we have active growth. Okay. In low birth weight infants having birth weight less than 1,500 grams, supplementation with vitamin D, calcium, and phosphorus is required, okay, especially if they are breastfed to guard against rickets of low birth weight. When we have established rickets, so the treatment will be with the therapeutic dose of vitamin D, which is 5,000 to 10,000 international units given daily for usually at least 2 months, okay, for several months, combined with oral calcium supplements, very important to avoid hypocalcemia, and monitoring of the dose by serum phosphate level that usually normalized by vitamin D replacement and by radiographic healing evidence, okay, having this characteristic line of calcification due to mineralization and deposition of calcium at the site of growth plate. Okay, this can be visualized even after 1 week of vitamin D replacement. Okay, so this is how we monitor the therapeutic dose that should be continued till complete healing of the rickety manifestations. Sometimes single day of 600,000 international unit of vitamin D is given in 4 to 6 oral doses or given as IM injections or over 3 times maybe. This can be used in case of poor compliance. Okay, so vitamin D is well stored in the body, and so it will be released gradually even after giving this very large dose at short intervals, but there are some claims that these high doses may precipitate hypercalcemia and nephrocalcinosis. But with the issue of compliance, we may resort to this very high dose. So when we have started our therapeutic dose of vitamin D, we have mentioned that evidence of healing is can be visualized within even 1 or 2 weeks by the healing line in the plain radiograph, and by normalization of phosphorus levels, by reduction of alkaline phosphatase level. But sometimes during monitoring, failure to respond to vitamin D replacement is found, and in this case you should think of the non-vitamin D deficiency rickets. Okay, rickets that is not caused by vitamin D deficiency. So nutritional rickets is the most common, especially in breastfeeding without supplements, and in case of skin pigmentation. And this is a common question in the exam, giving you an infant, okay, or young child, maybe from Africa, Sudan, and he is darkly pigmented, okay, and okay, asking about his condition, usually have rickets due to skin pigmentation deprivation from UV light. The other causes that are not related to the nutritional vitamin D deficiency is the malabsorption, having cases with fat malabsorption, specifically as vitamin D is fat-soluble vitamin. So having exocrine pancreatic insufficiency for whatever cause, maybe chronic pancreatitis, maybe cystic fibrosis, whatever the cause, this can result in failure of absorption of vitamin D. Okay, so prolonged and high doses of vitamin D will be necessary. Also, celiac disease associated with generalized malabsorptive state can be associated with failure to respond to the oral vitamin D supplementation. Other causes of rickets may include the chronic kidney disease due to failure of activation of vitamin D at by the 1-alpha hydroxylase enzyme. Okay, so deficiency of the active form will be found, and so on. Continuing our investigations, level of 25 hydroxy vitamin D will be normal, but doing the level of 125 hydroxy vitamin D will be low. Okay, genetic testing for the 1-alpha hydroxylase can be done if in the rare cases associated with 1-alpha hydroxylase deficiency. Also, chronic renal failure itself associated with renal osteodystrophy that was discussed in the chapter of nephrology. Okay, and this is a cause of rickets then. So treatment of the main condition of the kidney plus supplementation with the calcium and vitamin D is necessary. Also, liver disease will be associated with failure of activation of the inactive form of vitamin D. Some medications like anti-epileptics, for example, phenytoin, for example, phenobarbital, these increase vitamin D metabolism, and they can be associated with rickets due to increase in vitamin D metabolism. Sometimes the rickets is caused by genetic mutations, okay, and these include the vitamin D dependent rickets type 1, vitamin D dependent rickets type 1 that is caused by genetic mutation encoding for the 1-alpha hydroxylase enzyme, resulting in its deficiency, resulting in failure of activation of vitamin D in the kidney. Okay, as we have mentioned, the labs will show you a normal level of 25 hydroxy vitamin D, but low levels of 125 hydroxy vitamin D. Plus the other characteristic lab features of rickets, including the low normal ionized calcium, plus low phosphorus, plus high alkaline phosphatase, plus the radiological features, plus the high parathormone level. Okay, the definitive diagnosis will be by gene testing, maybe. So the treatment of this not by the inactive form of vitamin D used in nutritional rickets, vitamin D2 or vitamin D3, but here the treatment will be in the form of calcitriol, which is the active form, which is 125 vitamin D, or the alpha calcidol, which is 1 hydroxy vitamin D. Okay, so it is a synthetic form that is hydroxylated at the site 1. Okay, so 1 hydroxy vitamin D. Calcitriol or alpha calcidol would be the treatment in this case. We have vitamin D dependent type 2 rickets, which is caused by resistance of vitamin D. It is end organ resistance to vitamin D. This is the cause. And so your labs will show you the low calcium, low phosphorus, high alkaline phosphatase, high parathormone, the radiographic features, plus normal or high levels of vitamin D levels. Okay, and in this case you should think of resistance to vitamin D, and the treatment here will be in the form of very high doses of vitamin D given daily for life, okay, either the active or the inactive form. Number 3 of genetic rickets is the X-linked hypophosphatemic rickets. We have discussed in the chapter of nephrology. It is a genetic mutation in the FEX gene, FEX, which is phosphate regulating endopeptidase gene, phosphate regulating endopeptidase. It is X-linked dominant condition presenting in both males and females, and usually you find that the child and his parent are short and have the very characteristic features of rickets. Okay, treatment in this condition will be here in this mutation there is increase in phosphate loss in urine. So it is not related to vitamin D deficiency, not related to vitamin D resistance, not related to calcium abnormality, but it is related to phosphorus loss in urine. Okay, the treatment will be in the form of the active form of vitamin D plus phosphate supplements. Very important. Okay, look at this boy with X-linked hypophosphatemic rickets, being short, with disproportionate short stature, with characteristic bowing of legs. Okay, so now to another important but less common entity, which is the juvenile idiopathic arthritis, which is a chronic arthritis of unknown etiology. Being a chronic, it persists at least for 6 consecutive weeks. So we have criteria for diagnosis, okay, starting with chronic arthritis that lasts for at least 6 consecutive weeks, which can affect one joint or more, and with its onset before 16th birthday, okay, after exclusion of other causes of arthritis, which are many. Okay, it has prevalence of 1 to 20 per 100,000. Okay, it is a chronic inflammation of synovium with lymphocyte infiltration and release of cytokines. These cytokines include interleukin 6 and the tumor necrosis factor. Okay, so we have arthritis, and by arthritis we mean that we have swelling, we have hotness, we have redness, we have limitation of movement of the joint. These are the defining criteria of arthritis. It differs from arthralgia, which is in the form of just pain in the joint without any signs of these. Okay, these signs include swelling of the joint, hotness, redness, okay, and the limitation of movement of the joints. Very, very important to be at least 6 consecutive weeks, and with the onset being before the 16th birthday. Based on the mode of onset, during first 6 months of presentation of JIA, we have these categories of JIA. Systemic onset or Stell's disease, polyarticular JIA, rheumatoid factor negative and rheumatoid factor positive, oligoarticular, which can be persistent or can be extended, and Enthesitis-related arthritis or the Ankylosing Spondylitis, also the psoriatic JIA related to psoriasis, and some are unclassified. Starting with systemic onset JIA or Stell's disease. Stell's disease can occur in either male or female, no sex predilection. Most commonly, the onset is between 1 and 5 years. So it is disease of younger children, characterized by being systemic onset, which means that usually it doesn't start with arthritis. Okay, joint disease can, in a high percentage of patients, not evident at the onset. Okay, the onset usually start with systemic manifestations, and the joint disease may appear several months later, maybe. Okay. So systemic manifestations in the form of fever that has characteristic feature of being quotidian, which means it spikes once during the day. Okay, only once during the day. It may reach up to 39 or 40 degrees. Okay, 1 or 2 spikes. This is called quotidian fever with a characteristic rash that is evanescent rash, which means with subsidence of the fever, okay, the rash appears. This rash is salmon pink, okay, non-periodic rash being on the trunk and on extremities. Can be in the systemic onset associated with arthralgia only rather than arthritis. Arthritis may not occur 4 months after onset. With other systemic manifestations include the following as being a systemic inflammatory disease, so hyperplasia of the reticuloendothelial system in the form of generalized lymphadenopathy, hepatosplenomegaly can be found, anemia also usually evident in this disease, serositis or inflammation of serous membranes including the pericardium as appear in this X-ray showing pericardial effusion associated with Stell's disease. Also abdominal pain from peritonitis or bilirubin can accompany the onset. Labs will show anemia, very characteristic, that is progressive, associated with leukocytosis usually and thrombocytosis. So leukopenia or thrombocytopenia is not a feature of juvenile idiopathic arthritis, okay? But as an inflammatory condition, we have leukocytosis and thrombocytosis. Acute phase reactants expected to be high, ESR, CRB, and serum ferritin. Rheumatoid factor usually negative, okay, and ANA also negative. Usually this disease has poor prognosis, especially in younger ages. The younger the age of onset, the greater risk of poor growth and osteoporosis. 50% may have recurrent episode, and a third of cases have progressive arthritis later on. This is the Stell's disease or the systemic-onset JIA. The other entity is called Oligoarticular JIA, and this is disease of girls mainly who are young, less than 6 years. This is the most common subtype of juvenile idiopathic arthritis. The most frequent occurring subtype is oligoarticular JIA when 4 joints or less are affected, okay, during the first 6 months of disease. Usually the knee, okay, or the ankle is the first presentation in this entity, okay. So maybe just 1 joint, maybe up to 4 joints are affected. So this is oligoarticular, okay. After 6 months, we can categorize it into limited, okay, if the disease persisting in less than 4 joints, or it can be extended having poorer prognosis if 5 or more of the joints are affected after 6 months. Okay. Anterior uveitis is very, very important to remember that all cases of juvenile idiopathic arthritis, you should consider the possibility of uveitis, anterior uveitis or iridocyclitis, which can be silent, okay, presenting with no symptoms, and can be vision threatening in a percentage of cases, okay, can be bilateral also in 2/3 of cases. So slit lamp examination every 3 months is mandatory and should be routine in the first 4 years of the presentation. Course of uveitis characteristically is independent of joint disease, okay, and its prognosis depend on early detection and appropriate intervention in these cases, okay. This picture for anterior uveitis that can be complicated by keratopathy, can be complicated by synechia, and ending finally by vision loss, okay. ANA or anti-nuclear antibodies often present, and when ANA is positive, risk for uveitis is higher. This is very important, and you would be asked about it in the exam frequently. Full blood count here is normal, rheumatoid factor is negative. The most effective treatment line is intra-articular steroid injection. Then we have the other entity, which is polyarticular JIA. Okay, this polyarticular can have positive or negative rheumatoid factor, and notice that rheumatoid factor is one of the acute phase reactants, okay, that can be high even in healthy children during any intercurrent illness, so should be interpreted cautiously. By polyarticular we mean at least having 5 joints are affected or more can be affected during the first 6 months of life. Of onset of the disease, okay. So based on mode of onset of the disease, we categorize the JIA. So the disease can be rheumatoid factor negative or positive. In rheumatoid factor negative disease, large or small joints can be affected, okay, and even symmetrical. ANA can be positive here, okay, with a risk of uveitis related to the positivity of ANA. Even cervical spine and the temporomandibular joint can be affected, with remission rate may reach up to 50% of cases, but on the other hand, recurrent episodes can result in progressive deformity. So having polyarticular juvenile idiopathic arthritis, that is less common than the oligoarticular. Oligoarticular is the most common. Okay, so affection of temporomandibular joint can be present. Even cervical spine can be affected by polyarticular JIA. Large joints like the knee joint or ankle joint can be affected with manifestations of arthritis that we have mentioned. Limitation of range of movement, hotness, redness, and swelling. Small joints also of interphalangeal and metacarbophalangeal joints can be involved. Okay, having at least, as we have mentioned, 5 joints are affected. Even the JIA can end by limb length discrepancy or elongation of one joint by the active inflammation can result in one leg is longer than the other, or limb length discrepancy. About polyarticular JIA, that is rheumatoid factor positive. This is more common in girls, which peaks in adolescence. When it is rheumatoid factor positive, so it is aggressive, okay, and associated with symmetrical arthritis, okay. Small joints mainly who are affected, okay, of wrists, hands, ankles, and feet. Prognosis here is poor, with severe joint destruction can occur with recurrent episodes of arthritis. Another entity is called Enthesitis-related arthritis or Juvenile Ankylosing Spondylitis. It is the old name, Juvenile Ankylosing Spondylitis, that is known to start with low back pain, especially in the morning, that usually improve along the day and so on. Now it's called the Enthesitis-related arthritis. Okay, and by enthesitis we mean the inflammation in site of insertion of tendons, okay, and the ligaments. This is the normal Achilles, okay, inserted here in the calcaneus bone, and this is the inflamed joint that is enthesitis related. We have inflammation at the site of insertion of the tendo-Achilles with the swelling, as you can see, and redness and hotness and limitation of movement. So this affects males more, especially after 8 years of age. Lower limb arthritis with enthesitis, inflammation of ligament, tendon insertion, tendo-Achilles, patella tendon are commonly affected. Also can be associated with acute uveitis, especially if ANA positive, with painful red eyes. Spinal joints can be affected, presenting with back pain, as we have mentioned, but is this not common in pediatric age group, maybe in adults more. Also sacroiliac disease can be present, okay, but this is uncommon in children, despite it can be the first presenting symptom, and so the name. IgM rheumatoid factor here is negative, but very, very important. We have association with HLA-P27 in 90% of cases. You should remember this, the relation to HLA-P27. We have differential diagnosis for this association. We will mention it. Outcome of this condition is favorable. Psoriatic arthritis, we have criteria, okay, when we have psoriasis, which is a dermatological disease that has a strong family history, okay, plus arthritis, we call it psoriatic arthritis, and this is a distinct entity having its prognosis and treatment and so on. Or sometimes we may have, we have criteria for a diagnosis of psoriatic arthritis. You may have signs of arthritis plus at least 2 of having dactylitis, okay, which is swelling affecting fingers, okay, which usually in psoriasis affect single finger like this, and here also the single finger is affected with limitation of the flexor movement, as you can see here in the ring finger. So having arthritis plus dactylitis plus nail biting, okay, very characteristic, or oncholysis, or psoriasis in a first degree relative, okay, so any 2 of these plus having arthritis diagnose psoriatic arthritis. This affects females more and usually asymmetrical arthritis with flexor tenosynoviitis, as you can see here. Single digit may be affected, also uveitis can occur, and usually as immune condition it has remitting and relapsing courses. So what is the differential diagnosis of juvenile idiopathic arthritis? Okay, if you have single swollen joint like this, you may think of septic arthritis, first possibility, as it is a medical emergency that should be excluded, followed by reactive arthritis as a common very common presentation in childhood after maybe upper respiratory tract infection. You may think of rheumatic fever, but this when it is migratory and affect large joints and associated with other joints criteria of rheumatic fever, or it may be post-infectious arthritis after infection. So this is differential diagnosis of single swollen joint, but if you have multiple joints, look at these characteristic polyarticular disease with the characteristic rheumatoid nodules that can be seen as a form of vasculitis associated with the condition. So when you have joint disease plus systemic manifestations, it is a systemic disease. You should think of systemic lupus as a cause, or you should think of juvenile dermatomyositis. You should think of polyarthritis nodosa. If you have features of vasculitis plus the characteristic nodules along the vessels, this is very important. You should think of malignancy, leukemia. 60% of cases of leukemia present with MSK manifestations, musculoskeletal manifestations, the form of bone pains, arthralgia, arthritis, and so on. Also, inflammatory bowel disease have some extraintestinal manifestations, with arthritis is a part of it. So how to assess? Be noticed, as we have mentioned, rheumatoid factor is acute phase reactant. It's not conclusive. You should interpret it cautiously. It can be elevated in healthy children during intercurrent illness. Thrombocytopenia or neutropenia is not a feature of JIA usually, and you should consider other causes like systemic lupus, and leukemia. Relative lymphocytosis also is common with JIA, so having lymphopenia or neutropenia, you should consider other diagnoses like leukemia. 60% of leukemia cases present with MSK manifestations. Also, neuroblastoma, very commonly associated with bone pains and joint manifestations. MRI, usually diagnostic modality of choice, to show this is MRI on the knee joint in case of JIA with the synovial hypertrophy. You can visualize the cartilage, you can visualize bone and the bone marrow by the MRI. By ultrasound, you can diagnose joint effusions, synovial hypertrophy associated with the arthritis and the synovitis. Tendon pathology can be visualized. The management of JIA, usually multidisciplinary, require lines of treatment, starting by physiotherapy. Very important, you need multidisciplinary team, including the physiotherapist, very important, occupational therapist, very important, ophthalmologist for the eye disease, also the orthopedic surgeon, you may need him, dermatologist in case of psoriasis, you need also others. This is drug therapy. You need psychological and also support, very important. You need social worker to support him with the aids he need, and so on. So it is multidisciplinary, starting by physiotherapy, aiming at to maintain joint function and the muscle strength, avoid disuse or misuse atrophy. And the loss of function of the joint by the inflammation and the loss of muscle mass, and so on. So physiotherapy is very, very important after subsidence of the inflammatory process. Patients are encouraged to be active, practicing exercising. Sometimes splinting of the joint is used to prevent deformity and preserve the function, may be needed but less often used now. By occupational therapy, we means if we have some hand problems, so helping the patient to get great benefit through the fine motor skills. This is occupational therapy. You should monitor uveitis, as we have mentioned, routinely every 3 months by slit lamp examination, as uveitis is silent, and usually present without manifestations and is vision threatening. Drug therapy for the JIA includes the anti-inflammatory medication, starting with usually the non-steroidal anti-inflammatory drugs. So you may start with morphine, for example, as first line of treatment to relieve the pain and to relieve inflammation, and in case of fever. And based on the clinical course, you may add corticosteroids that can be used orally, IV in severe cases, or intra-articular as the most effective in case of oligoarticular JIA. This is the anti-inflammatory lines. Other lines include disease-modifying anti-rheumatic drugs, with methotrexate is the main line of treatment of GIA. Okay, sometimes sulfasalazine is used, especially if the arthritis is associated with inflammatory bowel disease. Hydroxychloroquine is used also, especially in cases of systemic lupus. These are the disease-modifying anti-rheumatic medications. The next line, which is commonly used now beside methotrexate in case of failure or inadequate response to methotrexate. These biological agents inhibit cytokine, okay, especially the tumor necrosis factor alpha, as we have mentioned. We usually the first discovered is infliximab, which is which attack the tumor necrosis factor alpha. Okay, sometimes the intolerable side effect or inadequate response, so etanercept is commonly used, which attacks the tumor necrosis factor alpha receptor. Okay, so we have etanercept, we have infliximab, we have also the new adalimumab, also can inhibit tumor necrosis factor alpha. They are commonly used nowadays. Anakinra, okay, which is monoclonal antibodies that attack the interleukin-1. Okay, also can be used in case of systemic onset disease. This is drug therapy for GIA.